So with those words, I'd now like to pass over to our next speaker, Professor Yeoh from the Jockey Club Public Health Centre here in Hong Kong. And we look forward to hearing his perspective on NCDs in the 21st century and how design can take a key role in responding to those challenges. Thanks very much.
Professor Capone, Professor Delaney, distinguished speakers, guests, delegates, ladies and gentlemen. It's a great pleasure and privilege to be speaking today to such a distinguished audience. I'm a bit out of my league because I'm a public health physician now, although I was in policy before. Professor Delaney thought that it'd be interesting to talk about the challenges of non-communicable diseases. So I'll be talking about the overall challenges, and then to put into context of this international conference about some of the ecological, there's a typo there, models of health behavior, because it looks in terms of how we design systems to deal with these challenges of NCDs in the future. And I'll be talking about some of the behavioral elements of human behavior where designs can help to provide better choices, improving lifestyles. So this is, as you know, the WHO's definition of health. It's physical, mental, social well-being. So in terms of if you want healthy, how we design social systems and the neighborhoods around us also is part of that well-being that is required for health. And I'm sure you're familiar with all these figures. We have an aging and increasing population all over the world. And this looks at the correlations between aging and non-communicable disease mortality. And right throughout the different continents in the world, I think Professor Pang just now talked about in Vietnam. So this occurs all over, in Africa, in Asia, in Latin America. There's this very close correlation between populations over 60 and the mortality from non-communicable diseases. This shows, in fact, the projections that if there are no changes were to occur in age-specific risk, the green levels are the levels of deaths from NCD. The orange bars are the ones that will be the NCD deaths that will be related to population growth, and the blue band are the attribution of mortality due to population aging. So you can see that right through different continents, the same patterns occur. Because, as you know, people with aged people will tend to have non-communicable diseases. So we have this big issue that we all confront. But looking beyond deaths, we obviously know that people with non-communicable diseases have a lot of treatment requirements. There's disability, there's pain, there's suffering, there are costs involved. There are productivity costs which are substantial because it requires long-term management. Work attendance is affected, and there's premature removal from the workforce. Yeah. Just looking at Hong Kong, of people aged over 65, 75% suffer from one or more chronic diseases or non-communicable diseases. And in Hong Kong, where in our population about 7 million, about 59% of the people with non-communicable diseases, that's about 1.5 million people, are aged over 60. And of course, the bed days occupied are quite substantial. So non-communicable diseases is a serious challenge, but it's not the end. People who manage their non-communicable disease probably can enjoy health and good quality of life, and people who have severe NCDs can also have well-being. So there are two ends that I want to briefly talk about. This one briefly at the end, about aging in place. But I want to now concentrate on how do we prevent non-communicable diseases and the role of designs and the environment. As you know, lifestyle change is necessary. The underlying causes of chronic disease are the usual social determinants, but there are modifiable risk factors. And there are three which are very important: diet, activity, and tobacco use. And these are the three most common modifiable risk factors. Okay? But when you look in terms of lifestyle changes, I think we all confront it on a day-to-day basis. How many of us make resolves to exercise and we don't? How many of us make resolves to have healthy diets, and then we relapse back to that? So in terms of changes in terms of individual lifestyles, you require knowledge, you require motivation, you require skills. But most people have found that, in fact, a lot of these things are not sustainable. You have small changes. But what you actually then can help are policies and environments. So the environmental context, the built and policy environments are often barriers to change, and how do we actually enable it and remove these barriers? So I think it's the interaction of individual decisions helped by the environment and by policies. So this is what I'm going to talk about. Yeah. So one then looks at a more ecological perspective, because in changing lifestyles, public health scientists have very traditionally been putting it on the individual, looking at what makes people change behaviors. But when you look at in ecology, we live in a society. We are influenced by social and community networks. The living and working conditions and the general socio-economic environment all impact in terms of our decisions to adopt some of these healthy lifestyles. And most of the ecological models of health behavior, there are many, have four core principles. First, there are multiple levels of influence. So we are being influenced all the time at different levels. The influences interact across levels. So it's part of systems theory. So we don't live in isolation. Many of these are interacting, they're complex. And they are behavior specific. And interventions, to be sustainable, need to be targeted at multiple levels. So you just can't give incentives for people and expect them to continue, because people have found that incentives don't work after a time. And even changing behaviors, teaching people how to adopt healthy lifestyles, it's not sustainable. There are some changes, but they disappear with time. So when you look at the ecological models of health behavior, there's the intrapersonal, your own biological and psychological makeup, interpersonal, the social and cultural, how the organization community supports it, the physical environment, which is a very important part of this conference, can enable or be barriers, and policies. So sustainable behavior change requires motivated, educated individuals, conducive environments and policy support, social norms, and social support. So these are the very context in terms of how we should be designing our programs to enable people to lead healthy lifestyles and prevent this epidemic of NCDs that we're going to see. Yeah. So this is an example of diabetes, self-managed example, how they interact. So because of time, I won't be going to the details. And all these really started with Bromf and Brenner's ecology systems theory, where they look at 5 systems: the microsystem, the individuals; the mesosystems, this interconnection between the various components of our microenvironment, the family, the schools, etc. Ecosystems are the societal functions. The macrosystem is the broad socioeconomic status. But I put this up because there's one important point here, which most people haven't covered, the so-called chronosystem, the time. So the environmental events and transitions over the life course. Those are all the elements in terms of how our human behaviors and development take place. So one must be mindful that the history is important, the events that occur. So these are all things that we do when we look at how we want to change lifestyles and improve our behaviors so that we have less NCD. So WHO talks about, to reduce modifiable risk factors for NCDs, we have to create health-promoting environments. So obviously the ones that I'm familiar with, housing designs to affect the ability of older people and ability to continue to live comfortably at home. We look at accommodation with surfaces, elevators, rails and non-slip floorings, passageways, doors wide enough for wheelchairs. So I'm sure that all these have been covered, but that's just a reminder of the things we do. But equally important, I see also in this conference, neighborhood designs are very important. The walkability of neighborhoods, the distance of the shops and the facilities from where you are. In Hong Kong, I've noticed many years ago that we have a lot of centers, exercise centers, but it's so remote. You have to go through an underpass. They're not accessible, so people don't go there. So we have a lot of these facilities, but government, in terms of planning, will pitch them in areas where they are not where people live. And I remember one center that I went to, you had to go down a bypass before you could get there, and it was isolated from anything else in the community. So there's no use. So the design of physical environments, the convenience, availability, the range of facilities, they're all very important if we really want to have a healthy society. The other element of it is social environments. The community centers, because how you build centers will also help build the community. So the environment factors not only helps individuals, but also how you then structure communities. So communities can work together and support one another and improve and support healthy lifestyles. So very important components and intergenerational elements, because with aging, we have ageism. So the intergeneration elements are very important in terms of design of the environments. So designing a healthy environment, I'm sure all of you know, it's what message does this give you? Does this design support separate smokers and non-smokers? Does it encourage people to quit? Or is it a trigger for people who smoke to say, I'll go there and smoke? So it's a trigger for people. So some of these things, one needs to give some thought in terms of how, even when you have these, do you have an area where it's so that it's like inviting people to go and smoke? So it triggers responses from people. Right? So the environment should be designed to facilitate healthier choices. And these healthy choices are not a one-off switch. We also think about people being rational, but the lifestyle change continues long-term effort, riddled with barriers. So there are lots of barriers. So just use the experience of a person who wants to be active. You have the barriers in terms of the time, the energy, your health, and then in terms of time, your balance between work and family. You're wanting to put more time in work so that you have more income to support your family. So there are many of these decisions that you take place. So there are many barriers in terms of daily decisions of wanting to adopt healthy lifestyles. So difficulties in making choice. Usually one-off decisions are easier. So if you make a decision to do an organ transplant, it takes effort, but you can make it easier. But the example I've shown you about the choice to be active is really quite complex. Smokers are constantly attacked by cravings, withdrawals, and then by those things that will trigger them off in terms of smoking, as I demonstrate to you. And one very interesting research which was found in terms of healthy diets. People, they looked at the number of decisions that you make in terms of what you want to eat every day. And they quantified that you make 200 to 300 decisions in typical today of what to eat, when to eat, how to eat, and how to prepare for it. So these would be beverages, meals, etc. And over 200 decisions. Do we think about it? We don't, right? But they are decisions. So they look at the human behavior, how our human mind works. People talk about the so-called two systems, default systems. Systems are the so-called automatic systems. We don't think about it because many of the decisions are not in the conscious arena. And that's why in terms of the designs, they're quite important because certain cues will make you automatically do certain things. So when you go to the supermarket, you see a lot of very attractive things and you just buy it without thinking. So many of these are rapid intuitive solutions. They're associative, they're influenced by context. They're sensitive to immediate pleasure, they save cognitive effort. And the so-called slow system takes over when the default system feels wrong. It's controlled, deliberative, depending on cognitive capacity. And there's an interaction of the two. Obviously, you can't have just one, deal with one without dealing with the other. But the two are very interactive. And one needs to be mindful that a lot of the automatic systems are in function all the time. So as we are sitting here, our subconscious, our automatic systems keep on getting cues. So in our mind, a lot of decisions are taking place. There are certain things that trigger you to think that, oh, maybe after this session, I might want to eat a bit of stuff because there's a picture there that reminded you that you might like ice cream or coffee or whatever. So that triggers you in terms of, but you are not even conscious of it. So I think we need to understand how systems work so our designs can help, can facilitate better lifestyles. So decision-making, so as I said, we are not aware of those 300 dietary decisions that we make every day because we don't actually think about it. We require deliberative thoughts, and then we have our reflexive systems. So typically, we use rule of thumbs to make shortcuts to the automatic system. So the cues are there. So I just want to talk a bit about so-called choice architecture. So it's architecture not in terms of designing things, but designing choices. So how the choice is not between healthy and unhealthy. Thaler talked about choice architecture to reflect the needs to design systems that so-called nudge people. So you just move people, nudge them a bit to more desirable behaviors. Examples were opt-out, because in many countries where you have a donation, the opt-in and opt-out one helps, because people just are too lazy, it took too much effort to say that I want to opt-in for organ transplant. So usually it's an opt-out system. But if you require people to opt-in, then you find that fewer people are likely to sign the thing, because it takes effort. So that some of these things are making these choices, making it easier for people to make the right choice. So it's a process design system service in a way that good choice is easy and rewarding. It does not take much effort. So there are tools for choice architecture. There are feedbacks, understanding complex choices, understanding mappings in terms of how we make decisions, expecting doing default so that they, by default, will do the healthy choices, etc., and creating incentives. So there are these tools that one can look at. So they are like guided choices so that people will tend more to use it. And this is also quite interesting. This is, how would you open this door? You're looking at the handle, you pull it, isn't it? But it doesn't work that way. This is a push one. So so when you don't have this, you might just push. So the stimulus response comparatively is quite important, because it's how our mind triggers these things. So those automatic responses that I talk about. So the stimulus and the response must be compatible. Seeing flat plates on the door signals pushing, handles on the door signals pulling. So if you have handles, very often you see handles on both sides, and that violates the stimulus-response compatibility. So simple things like that. The impact in terms of how do we actually encourage people to make these right choices. So I talked about these good designs. And of course, finally, about empathy, that when we design things, we do it from top down, but we should be understanding that there's a whole diversity of people. We should be more empathetic to their needs so that we design things that help them. So to borrow from design thinking, choice architects, Brown proposed, should be more empathetic. They should assume the beginner's mindset. Don't assume experts have all the answers. And not to settle for middle ground, and look for positive deviance, because they are performing to desired behavior to a high degree, and it will provide very important insights. And finally, I just want to talk about aging in place. So when we have NCDs, we also non-communicable diseases, we have people who are older, they live, they have disabilities. So how do we then enable people to live in the community? Because it's much better quality. It's a lower cost, because in Vietnam you have these problems of bed days, but how many of those patients can be better dealt with at home? And we don't have the environments that enable people to live at home. There have been many innovations in many countries. In America, because the system is very pluralistic, the so-called PACE program, which was piloted, and there are retirement village concepts in America where people live in communities and support one another. So all these things are quite important in terms of providing those sort of environments where people, the people as they age and NCDs, they may have disabilities, but they still continue to contribute in communities. There has intergenerational reactions. So how do we actually design those things so more and more people can continue to age actively in place, even they have NCDs? And they contribute to the communities that they live in, because people have found that that many people with disabilities have still many abilities that are not captured. The more we do things for people, the more they're dependent on you. But you find a lot of capacities in the community. So in the design of our societies, in the design of the social environment, how do architects and planners and the policymakers enable this to occur? And so that you also have environments that will provide good choice, to create good choices and user experience. And that, I think, is the future for managing non-communicable diseases in an aging society. Okay? So how do we construct choice environment so that sensitive people will want to come to the parks and make other healthy life choices. So just one example. Thank you very much.